welcome to Tech Medicos. Today we'll be discussing about the clinical history and examination of a parotid swelling. Okay, we'll be learning how to ask various types of histories in a parotid swelling and what all are the significance of those histories and how to make a clinical diagnosis and rule out other possibilities. Okay, so let's get started. First is chief complaint. Every history taking you start with a chief complaint. First the patient details and then you tell about the chief complaints, right? So here also we have the patient details and then the chief complaint here is swelling which is below and behind the right ear for past 3 weeks. Okay, this tells us that maybe this area since it is the parotid region, maybe this swelling is parotid. Okay, and it can also be lymph node or any other salivary gland swelling, but mostly it is parotid. Okay, then moving on to history of presenting illness, the patient was apparently normal 3 weeks back. Okay, after which he developed a swelling behind the right ear which was insidious in onset and it progressively increased in size. Okay, it is not associated with pain. Okay, this tells us that uh, if the swelling, see, if the swelling was associated with pain, then it will have the following causes like parotitis, which is the inflammation of the parotid gland. There is parotid abscess, which is the pus collection or infection of the parotid gland. Then there is pleomorphic adenoma, which is a benign tumor converting into malignancy. Okay, and a stone. Okay, so these four histories would have been present, like these four possibilities could have been there if there was a history of pain along with the swelling, but it is not there, so we can just rule out these things for now. Then moving on to no sudden increase in size. Okay, so he told already that the swelling gradually developed, it didn't like instantly appear. That tells us that it is not a malignant swelling. If there is a rapid increase in size, then we can say it is a malignant swelling. Next, no history of difficulty in opening the mouth. Okay, if there was a difficulty in opening the mouth, we can tell that it is a malignant swelling because in malignancy it infiltrates the temporomandibular joint and making it like unable to move. Okay, next, no history of difficulty in swallowing means see, if there is deep lobe involvement, if there is a deep lobe involvement, then there is a dysphagia and the tonsil can be pushed to the other side. Okay, or medially if there is a deep lobe involvement, but here it is not present. Okay, so there is no history of difficulty in swallowing. Then increase in size or pain during chewing is not present. Okay, if you are having obstruction in the duct, when you eat, saliva will be produced. Okay, but it will get collected in the gland only because the duct is obstructed, it can't come to your mouth, so it will be collecting in the gland and it will cause a tension in the gland because of the obstruction, and it will keep tensing up and then you will have pain and the size will increase because of that. Okay, so this is not present in our case. It is for duct obstructed with stone. Okay, no history of trauma. See, if there is a trauma, it can have complications later on, and it can either cause like abscess formation or like those complications, so that is not present with us. Then there is no history of fever. This no history of fever for us, it rules out the infections like mumps and abscess formation. Okay, because you know if there is an infection, mumps is a viral infection. Okay, and if it is present means there will be a history of fever, right? And mumps is common in childhood. Okay, so it is not present in our case. Our patient is a 55-year-old male. Okay, next, no history of ear discharge and ear pain. You know that parotid gland is situated just below the ear. If there is a cholesteatoma in ear, it can infiltrate the parotid gland and cause infection in parotid gland also, but that is not here. No ear discharge, no pain. Then no history of discharge from a sinus in parotid gland region. If there is a watery discharge present, means there is a parotid fistula. So this is also not present. We can rule out this. Next is drooling of saliva and difficulty in closing eyelid is not present. If this history is present, you know what it is. It is LMN facial nerve palsy. In facial nerve palsy, you will be having drooling of saliva, difficulty in closing eyelid, and there are other features which we will learn in the examination of facial nerve later on. So let's move to next other history. There is no history of swelling elsewhere in the body. Okay, this we say because we have to examine the lymph nodes of the neck or any other salivary gland tumor we have to ask, because see if there is a malignancy, okay, there will be parotid and submandibular group of lymph nodes enlargement, right? And if there is like Mikulicz syndrome, okay, that Mikulicz syndrome, it contains like it causes enlargement of mostly all the glands, okay, both the parotid, both the submandibular, both the sublingual glands. That is also not there. Then no history of dry mouth and dry eye. You know what it is. It is a Sjogren's syndrome. In Sjogren's syndrome, there is a triad. Okay, there is xerostomia, there is xerophthalmia, and there is rheumatoid arthritis. Okay, these three are the triad of Sjogren's syndrome. That is also not present. Then no history of irradiation. Okay, this irradiation will predispose to malignancy, so it is also not there. So we don't have this history. Fine. Next, past history. Past history, it's like all the other cases we ask about the similar complaints in the past, okay, or any history of TB, asthma, diabetes, jaundice, all that. Then chronic drug intake history, previous surgery history, radiation exposure history. Again, the same things we'll ask in all the case sheets. Nothing significant about parotid swelling in this history. Moving on to personal history. Okay, personal history. Okay, bowel bladder habits are normal and he consumes a mixed diet. That's okay. It's nothing important. What is important is non-smoker and non-alcoholic. Why? Because see, in if if a male is there is a male and he's a smoker. Okay, so there can be a possibility of Wharton's tumor, which is common in males who are smokers. Okay, so he's a non-smoker. We don't have this history. Then there is alcoholism. Okay, in chronic alcoholics, you know that before developing cirrhosis, there will be a parotid gland enlargement in there, like it is seen. We don't know the exact cause, but it is seen. So there will be sialoadenosis in those patients. So this guy is a non-smoker, non-alcoholic. We can rule out Wharton's tumor for now. But like we'll find the other findings also in examination, but for now we can keep it aside. And surely he's not a chronic alcoholic, nor there is a malignancy. Okay, then okay, so with the history itself, what all do we find? Okay, first the swelling is below and behind the ear, which indicates that it is a parotid swelling. Next, they told that there is no such history of facial nerve palsy, malignancy, or parotid fistula, parotid abscess, mumps. Okay, so all those can be ruled out. Okay, what is left with us is now benign lesions. Okay, what are benign lesions? Benign lesions, like they are the benign tumors of parotid gland, which are most common one is the pleomorphic adenoma, and the second most common is the Wharton's tumor. Okay, so this pleomorphic adenoma, we can for now we can keep pleomorphic adenoma as the option because we ruled out Wharton's tumor with the smoking history. Okay, but it's not completely ruled out. We have to examine to find out whether it is a Wharton's tumor or a pleomorphic adenoma. Next, general examination, the same thing. He's conscious, oriented, well built, nourished. There's no pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy. Nothing is present. Okay, everything is normal on general examination. Then this pulse rate, respiratory rate, everything normal. Then local examination. First, in every case sheet, you have to tell this that you will explain the procedure to the patient, get his consent. Okay, and you if there is any swelling, you have to examine it under the bright light. Okay, then we'll move on to inspection. On inspection, you don't touch the patient or anything. You just look and you tell whatever you can see. Okay, So here we can see a single hemispherical swelling of size 3 into 3 centimeter below and behind the right ear, right? Then border is well defined. Okay, extent, upper border, lower border, anterior, posterior, you can tell. Approximate idea. Okay, not, you don't have to touch the patient and tell. Next is skin over the swelling seems to be normal. If it was a parotid abscess, the skin can be bony, edematous, and pitting. Okay, but there's no pitting edema or anything like that. Then there are no scars, sinuses, dilated veins, visible pulsations. Okay, if the patient would have undergone any particular surgery previously, there would have been scars here, but he is not having any such thing. Then the lifting of ear lobule is present and retromandibular groove is obliterated. Okay, these two presentations in spectral findings, we can say that it is a pleomorphic adenoma, because classical features of pleomorphic adenoma are the swelling below and behind the ear, secondly the lifting of the ear lobule, and retromandibular groove is obliterated. Okay, so we can say it is a pleomorphic adenoma for now. Then no other swellings noted in the neck, means there is no lymph node present. Okay, then facial symmetry appears to be normal, that means there is no facial nerve involvement. On palpation, okay, there is no warmth and not tender. Okay, if it was warm and tender, it could have been a parotid abscess, but okay, it's not there. Then inspectory finding of side size, shape, and extent are confirmed on palpation. Then surface is smooth and skin is pinchable. Why do we ask this? We ask this to rule out malignancy, because if there was a malignancy, there will be infiltration of the malignancy to the skin. Okay, so that is also not there. Then consistency is firm. Okay, this consistency can be hard in malignancy, it can be soft in necrosis, and it can be soft cystic in Warden's tumor. In pleomorphic adenoma, it is firm. Okay, keep that in mind. Now, swelling is mobile in both vertical and horizontal direction, but not above the zygoma. Okay, this is curtain sign. You know that the this thing lower border of zygomatic bone is attached with the parotid fascia, so the swelling cannot go above that limit. Okay, that is what curtain sign is. Then no induration, no clenching of the teeth. On clenching of the teeth, mobility is not restricted. So this, why do we do this? Why do we check for this thing is because on clenching we'll tense the masseter muscle. Okay, and the contraction of the masseter muscle will tell us about the mobility. Okay, and it will tell us about the fixity of the bone. If it is a malignancy, there will be fixity to the masseter muscle. Okay, now no pre auricular or post auricular lymphadenopathy present. Okay, there is. Okay, now coming on to the this palpation, by digital palpation of Stenson's duct is done. Saliva oozes out, no discharge is there because there's no abscess, no infection. Okay, by manual palpation of parotid gland, no deep lobe enlargement. Okay, so we did bimanual palpation, there was no deep lobe enlargement. Also we can tell that the swelling is only superficial lobe is involved, and it is a pleomorphic adenoma. Till now, whatever findings we found out, we can make think in that way. Next, examination of the left parotid region is normal, means the same problem is not present there, only on the one side. Then examination of submandibular gland is normal. Examination of oral cavity is completely normal. Then examination of facial nerve. Okay, examination of facial nerve, what all will you see is, you will see the wrinkling of the forehead. Okay, if the wrinkling is absent, means there can be facial nerve palsy. If you will see if he is able to close the eyelids against resistance, and nasolabial folds are normal or not, no deviation of angle of mouth, able to blow cheek, anterior two-third of the tongue tastes normal, corneal reflexes are normal, conjunctival reflexes are normal. All these findings tells us that the facial nerve is normal. Okay, there is no palsy. Next, examination of head and neck lymph nodes. We already found out on the inspection and palpation that there was no other swelling, no lymph nodes were involved. Okay, then all the other systemic examination we did are normal, there is nothing abnormal about that. Then diagnosis, coming when you tell about the diagnosis, okay, you have to tell that there is a swelling, about what is the problem, then on which side it is there, where it is, and what is your probable diagnosis. Because right now you have you didn't do any investigation, so you can't just tell that I'm confirmed that it is this pleomorphic adenoma or any other diagnosis. Okay, you have to tell the probable diagnosis. Okay, then swelling in the right parotid region, most probably pleomorphic adenoma without deep lobe involvement or facial nerve involvement. Okay, that's what you have to tell, probably. Okay, what were the findings that uh, told us that it is a pleomorphic adenoma? Okay, pleomorphic adenoma, the swelling was below and behind the right ear. Secondly, there was lifting of the ear lobule. Third, there was retromandibular obliteration. Then, then we ruled out Wharton's tumor, and we ruled out malignancy, and all the other possibilities we ruled out. Okay, this is our most probable diagnosis. Next, moving on to management, we'll do the investigations. There are, okay, you will do two investigations, that is a basic investigation and a specific investigation. Basic investigation includes all this: blood count, total count, differential count, everything, ESR, serum sugar, urea, creatinine, everything you will do. In specific investigation we'll do FNAC. FNAC, it will uh, like rule out the malignancy and confirm our diagnosis of pleomorphic adenoma. Secondly, we'll do CECT neck. What are the indications of CECT scan is that if you are suspecting a skull base bone infiltration, then you should do. If you are suspecting mandible involvement, then you should do CT scan. If you want to assess the neck nodes, then you have to do CT scan. Next is MRI. Indications of MRI. Uh, Same thing. If you have a suspicion of malignancy, parapharyngeal spread is suspected, or perineal spread is suspected, and to find out the facial nerve status, you will do all this. Okay, these are the three investigations you will do. You must remember that in a slow growing tumor, you don't have to do biopsy, because if you do biopsy, there can be seeding of the tumor, and okay, that's all. Then treatment. Now see, we saw that there was no deep lobe involvement, only superficial lobe was involved. So we'll do superficial parotidectomy. Okay, and this you must remember that facial nerve conservation is very important in any parotidectomy. Unless it is like if the facial nerve is completely obliterated, you always do conservative surgery of, okay, and of parotid gland. You always conserve the facial nerve no matter what. Okay, now differential diagnosis. We saw that Wharton's tumor can be one benign oncocytoma, or there can be any parotid lymph node enlargement, right? So all these we can rule out. Wharton's tumor is seen in male smokers, and usually, okay, and on inspection and palpation, the swelling is soft and cystic. Whether that's all. Thank you guys for watching this video. I hope it was helpful for you in some way. If it was, then please tell me in the comment section. Thank you.